Or do with that.
Welcome, everyone, to today's program. I am Laura Dearda, Editor-in-Chief of Becker's ASC Review. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Cindy Klein is the Vice President and Chief Medical Officer at United Surgical Partners International. Mary Whittington is an Ambulatory Surgery Strategist for Cerner Corporation. It is now my pleasure to turn the floor over to Mary to begin today's webinar.
Good morning, everyone. It's our pleasure to be here today to talk about the patient safety and outcomes related to electronic health records. Electronic health records have gotten a lot of press recently, both in the ambulatory surgery space and obviously in the hospital space and physician offices. But we wanted to take a little different spin on it and talk a little bit about some of the positive things and some of the things to look out for as you go down the road of implementation of electronic health records when you're thinking of patient safety and quality. So our objectives today are to define how the electronic health record technology impacts patient safety and quality of care, and we're going to share some effective processes to utilize the information captured in the EHR to help you define some opportunities for patient safety improvement, as well as utilizing the EHR itself as a patient safety tool. We're going to define some clinical decision support tools that you might be able to use as part of the intelligence inside your electronic health record. The electronic health records are moving forward in the world to become more of an interoperability tool, an integration tool that affects patient outcomes across the continuum of care. So we want you to think about those kind of things as we move forward. We're going to explain what the intelligence behind the data means to you, so how you can use predictive algorithms, built-in risk assessments, and care pathways and more to help you drive standardized and evidence-based care. The time of just utilizing an electronic health record to replace your pen and paper is past. The expectation is that there is something that is done with the information you collect. So instead of just a documentation tool, it becomes a patient safety outcomes measurement, a tool that you can utilize the data that you find in the electronic health record, and you can utilize the record itself and the intelligence behind it to help drive some updated processes or new processes for you. Okay, so we're going to talk a little bit about the EHR and patient safety, and one of the things that we find is that you are driving consistent and intelligent record keeping. So from a required fields perspective, most EHRs can be set up to have required fields so that you eliminate the possibility for incomplete documentation or missing documentation that makes you vulnerable in the opportunity that you should happen to have being surveyed by a regulatory or accrediting body. So that's good that your documentation is then complete, right? And so forcing functions is a different technology or a different type of a process, and this is a lean methodology safety and patient safety improvement tool that's utilized in lean technology. So it's built-in hard stops in the process. So it is a task or an activity that forces the user to take action. So for example, if your system forces you to document a timeout before you can document anything further in the process, so the system says you've documented your patient in the room time and you've documented your anesthesia start time, you've documented your intubation time, those kind of things, and then the system recognizes that the next thing that's supposed to happen is that you're supposed to document a timeout before you document an incision time. So if the system is intelligent enough to be able to stop you at that point and say, hey, you can't move forward in your documentation until you document that timeout time. So those are the kind of things that are forcing functions as opposed to required fields. The system will allow you to build it so that your regulatory compliance standard documentation is met. So in an ASC specifically, there are requirements around what your H&P update note should say, or somewhere in your H&P it needs to say that the patient has been cleared for surgery in an ambulatory setting. And you can build templates and you can build standard documentation update notes so that they include that type of language so that it's easy for CMS and the other regulatory bodies to see that you're compliant with that language. The other thing is that your anesthesia discharge note can be a standardized note that anesthesia says the right things, like the patient has recovered from general anesthesia, so therefore you then are flipped over to being able to discharge based on protocol. So those are some of the things that the electronic health record can do for you. It allows you to have complete and legible, readily available information. So I know that when I was an ASC administrator and OR director in my past life, that one of the things I was guaranteed to be deficient on whenever any surveyor came into my organization was that I would not have signed, dated, and timed entries in all of my paper documentation. So the good thing about the EHR is that it will automatically, electronically sign those entries and place a date and time on it, so that absolutely takes away your possibility of a deficiency from a regulatory or accrediting body around electronic signatures or signatures dating and timing of entries. And Cindy is going to share a little bit of information about the summary of care documents and information across the continuum of care from the ASCs to the next provider.
Thank you, Mary. While there are good things in the EHR for patient safety and quality, we're also on a very long journey with healthcare technology, and a lot of what we want to do, a lot of the capability that we're dreaming of hasn't reached its potential yet. So you'll hear me talk a little bit about some of the downsides and some of the negatives and some of the realisms of using an EHR. And a summary of care document is one of those realisms. A summary of care document is a part of meaningful use, and it requires physicians and hospitals to provide a document with transfer or referral to another setting of care. ASCs are not included in meaningful use, and as a result, we don't have EHRs as prevalent as physicians and hospitals. And so our physicians and our hospitals are not able to send an electronic transfer of care document to our ASCs that don't have that EHR. Within the summary of care document, there's a lot of very good information that would be helpful to an ASC, and some of that information is active current medications, active current allergies, immunizations, prior care team information, problem lists. And so being able to share a summary of care document back and forth with providers helps, especially in the pre-admission process, to have that documentation up front when you're caring for the patient and help you prepare better for having that patient in your facility. So while physicians and hospitals are struggling right now to be able to share that summary of care document, in the long term, it is a document that will improve patient care for all settings. Closed-loop medication administration is one of my favorite areas in an EHR for patient safety. In all patient care areas, when a medication is being administered, the patient's wristband is scanned, the medication is scanned, and then the EHR goes out and looks at the orders and makes sure that this is the right patient, the right route, the right medication, the right dose. And if it is not, an alert is going to pop up on the screen and let the caregiver know that they're about to give something incorrect. The system will then document. The caregiver is going to administer the med, confirm the documentation, and once that documentation is confirmed, all the caregivers can see that that medication was given. From there, you can run reports, and you know who is using this process and who is not. Sometimes you have issues that are related to equipment. The medication scanners may be too difficult to use, your medication scanner may be down, and then other times you may have bigger issues like medication diversions. So having those reports on who is bypassing the closed-loop medication administration process can also be a big help in understanding your medication process within your facility. Patient safety starts at scheduling with your EHR, being able to have laterality, a required field, having a banner bar at the top of your screen that shows a picture of the patient and also displays laterality means that every step of the way, everybody is verifying to make sure that you've got the right information to prevent wrong sites. In an EHR, the focus on pre-admission is something that is going to add new safety into your process with risk assessments. As we move forward with interoperability, using those transfer of care documents, being able to get information from pharmacies, having the patient be able to complete their own data means that that pre-admission process, the nurse is going to spend more time with the patient and less time with paperwork. We just talked about closed-loop administration, which is going to help you with medication safety. Using evidence-based workflows within your EHR and common processes. As we go out and do our implementation processes at USPI, we do a lot of workflow assessments. One of the biggest areas that we see in workflow is lack of scripting, and where the patient is told different things in different ways at different steps along the process. So being able to add scripting, reducing redundancy in your documentation, and making sure that you have a common process for handoffs are all key areas that can help improve patient safety. Monitor connectivity is something that is difficult in ASCs, as a lot of our monitors don't have the ports that allow you to connect from monitors to your EHRs. If you are an ASC that is looking at implementing an EHR in the future and you have new equipment on your horizon, that is something you want to add to your checklist and make sure that you're thinking about as you buy new equipment, both anesthesia and PACU monitors, pre-op monitors, is to make sure that those monitors have ports that connect to your EHR. In ASCs, we are also doing some quality reporting. An EHR should take you beyond the ability to just report and give you the ability to build in more safety into your documentation. And as Mary was talking about earlier, being able to have those focused hard stops so that you kick off processes and protocols. With falls, that early identification in pre-op and PACU, all of that early documentation, making sure that is built into your documentation, making sure that your PAT person is starting that process of identifying risk. Burns, again, identifying your risk and using your protocols. Starting your wrong site at scheduling, making sure that you have a banner bar, everybody knows laterality, that you have hard stops in your documentation every step of the way. Transfers, making sure that you identify patients at risk. When we get to that point of sharing data, to be able to look at risk from prior providers to help identify patients who might be at possible risk for transfers. Antibiotic timing, making sure that you have those alerts, that all caregivers are being able to share that information, and that you know that that patient has been given that antibiotic timing on time. Mary, this one's yours.
Yep. Yeah, we have a, okay. So you're going to have to ignore my little red thing in the middle there. For some reason I got that slide from a different deck, sorry. So one of the things I wanted to say a little bit about Cindy's comment about monitor integration and equipment integration. Not only do you need to be sure that the ports on your that the ports are there for you to be able to physically connect the devices, but you also need to ask some questions, because this is a very important piece of patient safety, is collecting the information that the monitor can give so that the nurse is not documenting, or anesthesia is not worried about writing down the vital signs every time or putting those little X's on their anesthesia record. The devices are doing that for them, so then they can pay more attention to what's going on with the patient than what's going on with the devices. But your electronic health record vendor has different devices that they may or may not be certified, that those devices may not be certified by that vendor to be able to be utilized. So as you go through the process of picking an electronic health record vendor, then you can be sure to ask those questions so that you buy the appropriate equipment that is going to be certified against your vendor, or you're going to have spent a whole bunch of money on equipment that won't be certified by your vendor to be utilized. Okay, got the right slide, thank you. Okay, so we're going to talk a little bit about clinical decision support, and this is the intelligence inside the system. So your system should be able to do more, again, than just collect the information that you need to be able to document against the patient. It should provide you with some clinical decision support processes inside of that system. So what is clinical decision support? And it's a functionality that builds upon the foundation of an EHR. So the foundation is the information that you document, and then this provides persons involved in the care processes with general and person-specific information. So general information about the patient, and then person-specific information about the patient that is intelligently filtered and organized at appropriate times to enhance health and healthcare. And I know that many of you, or all of you, are participants in Becker's ASC review or Becker's Hospital review, maybe even in the Health IT review that they send out every day. And there's been a lot in that little publication about sepsis and preventing sepsis and sepsis algorithms and those kind of things. And so what those things do is they proactively look at what's happening with the patient that's being documented in the electronic health record, and then they bump that information up against the symptoms of sepsis and try to stop that before it gets started. So they want to identify your patient may be starting to have symptoms of sepsis, and you may want to intervene now in order to be able to proactively manage that condition. So there are other different things that you could also have associated with that. So say you're in the operating room with the patient and anesthesia is monitoring the patient. The piece of equipment that they're monitoring it with is documenting vital signs, and some changes start to occur within those vital signs that may or may not be identified by the anesthesiologist at that moment, but may be leading to a crisis situation. So based on what the patient's comorbidities and risk factors are and changes in their vital signs being documented in the record, those two things can intelligently come together and make recommendations to the anesthesiologist that he may be starting to have a problem with the patient's hypertension or blood sugar, or those kind of things that he may want to proactively manage. The clinical decision support the workflow without interrupting the provider's thought process or contributing to alert fatigue. Cindy's going to talk a little bit about alert fatigue here in a minute, but we build in these intelligence behind the scene to help the caregiver provide care, not to interrupt their work process and stop the care that they're providing. Okay, so the clinical decision support has 5 rights, so you want to be sure it's the right information to the right people. So obviously you don't want to send information or reminders or alerts to someone who doesn't have responsibility for that piece of the care process. Sorry about that. Okay, thank you. So, and you want to send it through the right channels. So physicians are very mobile, so it may be that you might want to send a reminder to the physician that he hasn't done his H&P and he needs to do that before he can move forward, and the system can help with that notification. When he pulls up his screen to look at his schedule, there can be an icon that says you need to do your H&P. You can also have the system send reminders to the nurse that she needs to redose an antibiotic. So for those of you who are thinking about higher level of acuity of cases in your ASCs, there are going to be things that come up with those higher level of acuity cases that you wouldn't think about today. So if you're starting a total joint program or a spine program and there's an antibiotic at this time and then 6 hours later or 4 hours later you need to redose that antibiotic, there are channels of information that can be provided to the nurse so that they don't forget to redose that antibiotic. And right intervention formats at the right points in the workflow. So if your CDS is effective, it must be relevant to those who can act on it, on the information in a way that supports the completion of the action. So you want the information and the intelligence in the system to help you perform your job, not to get in your way. So we talked about clinical alerts and reminders just a little bit, and talked a little bit about dosing antibiotics and medication interaction alerts. So when Cindy was talking about the closed-loop medication process, one of the things that is good about the closed-loop medication process is that it will give you an alert if indeed the medication either wasn't ordered for that patient, it's the wrong dose, those kind of things. It'll give you an alert around that. And it will also give you an alert if the medication is going to have a reaction with another medication that the patient may be on currently, if there's the potential for that reaction, and then also if the medication is something that the patient is documented to have been allergic to. And Cindy, you want to talk about the alert fatigue a little bit?
So some of the value that comes with having an EHR, it comes from the work the system does for you. Having your patient able to enter their information about their past history before they show up so that your pre-admission information flows directly into the EHR. Having the vitals from your monitors flow directly into the EHR. Those are values that come with the system doing work for you. Alerts are part of that value where you have information that pops up on your screen that lets you know important information, but it also has a downside, and that downside is that people get alert fatigue. Too many alerts means that no one's going to read them and they're going to click through them. So one of the things you have to ask yourself as you're building your system is, which of the alerts truly matter? Which one of them are going to be impacts? What can you turn off and still have patient safety, but not have alert fatigue? And some of that really comes with your medication alerts, especially in surgery. There are a lot of pain medication interaction alerts that are not necessary, that can be turned off, but all those decisions are part of your building your system, and it is something you absolutely have to have on your to-do list. Because if you don't, and you keep every alert that is built into a system, then none of your alerts are going to be worthwhile because people will just click through them.
Okay, and that is the reality, that a lot of the things that the systems are designed to do, as busy as caregivers are, can start to be taken for granted or ignored if indeed you have way too many pop-up boxes that pop up in front of your users. So as a nurse, when I'm looking at some of the new workflows that we're looking at here at Cerner, I always try to think about what does that mean for the nurse, and is she going to get value from what we're doing, or is she going to find it an interruption to her workflow? So one of the things we talked about is a little bit of evidence-based decision support at the point of care. So many of you are familiar with the Stop Bang questionnaire. So that is a questionnaire that's recognized across the country as being able to help you identify patients that may be obstructive sleep apnea, candidate for obstructive sleep apnea. And as you know, the three highest reasons for an ambulatory surgery patient to be admitted to a higher level of care is SATs that they can't keep up, so low SATs, and then post-op nausea and vomiting, intractable, and then pain management. So if we can, at the beginning of the process, and by that I mean before the patient arrives in your building, if we can identify patients at risk for some of these high-risk things that could turn them into an admission, then we want to be able to build in these risk assessments to be able to provide you with some type of an indicator, either a number or a high, medium, low kind of status. And then you can have protocols built into the system as well that will automatically that these numbers or these rankings will automatically trigger those protocols, the appropriate protocol for the ranking of the patient. So if you have obstructive sleep apnea questions and it says that the patient's a 3 and you do certain things for the patient that's a 3 that you wouldn't do for the patient that's a 2, then you can go ahead and have that nurse proactively have those things ready for the patient when they get there, and then also to be able to start that process as early as possible or turn that patient over to anesthesia for review. Post-op nausea and vomiting, then Aspen came out with a new post-op nausea and vomiting risk assessment a couple of years ago, about a year and a half ago. And so from Cerner's perspective, we built that into our system to be able to utilize that, particularly for the ASC environment, so that you could identify those patients that are high risk for post-op nausea and vomiting and adjust your antiemetic protocol accordingly. And also knowing that the ambulatory surgery center industry is very cost conscious, you also could see some reduction in medication use if you have an anesthesia group that just has the same antiemetic protocol no matter what the patient is having done or what their risk factor for post-op nausea and vomiting might be. The same with VTE risk assessments. Those can be built into the system to do the same thing. So those are all decision support tools that you can utilize to then drive evidence-based care. And you want to talk about the order sets a bit?
So our order sets, some of the really good that comes out of order sets in an EHR is the ability to run reports. And with that ability to run reports, you can see patterns and trends in physician care, especially in places where we struggle with physicians who aren't happy with VTE protocols and taking some of those VTE steps. Being able to have that data means that when you have those conversations with physicians, you have actual data to back up your conversation. So order sets are helpful in a lot of ways within improving care, but they're also helpful in giving you the data to make changes with your physician behavior.
Good. Okay, so in order to take the intelligence and proactively optimize your patient, some of the things that we talked about already were the risk assessments that you can use, and your patient engagement strategy. As you're thinking about it moving forward, there's a lot of patient-centric discussion out in the literature, the patient as the center as opposed to the provider as the center, whether it be the hospital or the ASC or the physician. So it's all moving towards the patient at the center. So if you think about how you manage your physical life, everybody knows how to access the ATM, how to look at their bank accounts online, how to make changes if you want to move money from one bank account to another, or you want to change your deductions. for your health care or for your 401ks, those kind of things. The same type of patient engagement in their physical health will be expected both by the patients and by the providers and the payers moving forward. So when you think about a portal, and portals are getting a lot of attention these days, so when you think about a portal, think about more than just collecting information on the front end from the patient to help you manage their care when they arrive at your organization. Think about other things that you can utilize that portal for, and be sure that whatever portal that you are considering has both the ability to push information to you or for you to be able to pull information out of it, and then also is it helpful to you to be able to engage with your patient by getting information to them. So you can, pre-op instructions can be sent to an email through the portal, or direct message to a text message to the patient through a secure message system that can be built in as part of your portal. So you can use those as communication tools so that you minimize the risk of the patient losing their pre-op instructions they got from the physician's office, or losing their post-op instructions that you gave them when they left the facility. So you electronically produce these lovely instructions for them to take home with them, and they signed them, and then they promptly lost them, and you can then send those electronically through the portal to the patient. So you've got two ways that you know the patient had those instructions and are more likely to follow them if they haven't lost the piece of paper. I don't know how many of you are participating in the optional functional screening for cataracts. So it's ASC QC11, and that is now optional, but I know that a lot of the single specialty eye facilities, ophthalmology facilities may be participating in this. One of the things your electronic health record can do for you is to help you identify those patients. So you did their screen at the beginning as part of your pre-op questionnaire, say, so you've asked the questions that you've chosen from whichever screen you're utilizing as your evidence-based screen, and then now you have to figure out how to keep track of that patient 90 days out. So you can, inside a system, have triggers that will make that patient show up 90 days out on your system as needing this screen, and then can be sent to them automatically through your portal so that they can go ahead and complete that screen and return it to you, and you don't even have to call them if you don't want to on that particular outcome. And so even though it is at this point voluntary, we've got some ways that you can automate that process. And again, with patient-entered outcomes data that can be sent back to your organization through the portal, as you are thinking about adding total joints and spine cases to your repertoire of procedures that you may be providing at your ASC, as you look at bundled payments, I don't know if a lot of you have read some of the things that have come out with bundled payments here recently in October, I think it was, or November. There are 67 regions that have been identified to be total joint bundled payment targets. So right now it's hospital-based because it's based on DRGs, but I am sure that as they move forward, the same thing will be required of the ambulatory surgery centers. And once those bundled payments come in, it's not just from the time you see the patient or from the time even the physician sees the patient till you're finished with the surgery. It goes out 90 days. So all of the outcomes that the patient has up to 90 days out are included in that bundle. So you are going to want to have some patient-entered outcomes data that comes back to you that shows that the patient is moving along like they should on their path to recovery. So I want you to think about that as part of your patient engagement strategy as well.
So Bill Bryson's book, A Walk in the Woods, reminds me a lot of our EHR ASC journey. In this book, he immediately, as he's preparing to go out and hike the Appalachian Trail, goes to the REI and buys all kinds of equipment, gets books about people who have gone and done the hike before. He buys maps. he goes out and looks for everything he can to help him prepare for his big walk in the woods. And that's kind of a lot of what we're all doing now. We are looking for everything that we can find that will help us along our journey, that will give us a map that will answer our questions, prepare us, and help us have a safe walk in the woods. As he's reading information about his walk, one of the big things that jumped out of him is not getting eaten by a bear. And so that is one of the things I think about most often as I'm preparing for ASC EHR journey is I don't want to get eaten by a bear. So how do we protect ourselves from not getting eaten by a bear? How do we not overbuy too much equipment that is going to be too heavy and we're not going to be able to carry on this long journey? So how do we prepare ourselves so that we don't fall into any of these places? The best way to do that is to look at the lessons learned from others. And our hospitals, our physicians have been on this journey a whole lot longer than we have. And so they have faced the bears and they have bought the heavy equipment that is heavy on their trail and weighing them down. So some of the things that we can take away from what our hospitals and our physicians have learned is the importance of the patient portal. In meaningful use, that patient portal is all about the patient going in and clicking and opening that portal. That's all that hospitals and physicians are concerned about right now, is making sure that they make their numbers by having that patient click on that button. For us in ASCs, since we don't have meaningful use staring at us, we can take a step back and look for ways to make that portal both a good business and quality decision. Having patient forms in the patient portal for both financial, pre-admission, and patient history means that you have good business and good clinical decisions and information that's flowing directly into your EHR up front. Information sharing, that transfer of care document that we talked about earlier, making sure that when we're exchanging information, it's the actual information that we need. In ASCs, we want an HMP, we want op notes, we want things that currently are not included in that transition of care. So as we are talking about information sharing, we have to have conversations about what's truly important to us in an ASC and making sure that we're not exchanging information just for the sake of sharing. Quality and patient safety at the time of service. One of the things that meaningful use requires of hospitals and physicians is the collection of a lot of patient information. A lot of times that patient information doesn't go any further than reporting it to meaningful use, but some of the things that are good in an EHR is the ability to have data that is collected at the time of service that we can then use after the fact to run reports and understand where we can make improvements, as opposed to what we currently do, which is retrospective collection of data on checklists and having people check boxes for the number of times they've washed their hands. If we can get away from that kind of collection of data and move more towards making sure that our documentation tells us what we need to know about our quality, we're going to both save time and improve our quality. Patient-reported outcomes, especially in ASCs, a lot of what happens to the patient after they leave the facility never gets back to us. So having a place where patients can come in and tell us what happened after they left also means that we can correlate infections back to sterilization, room temperatures, all the pieces that we documented at the time of service. Then once we know what happened after the patient left our building, we can look for patterns and trends in our documentation. When we're looking for value from our EHRs, having these lessons from our hospitals will help us be able to go back and see what has been done within meaningful use that has provided value, so that as we move forward in our journey with the ASCs, we don't get eaten by the bears and we're able to provide documentation of where our value is, as well as where we're getting a return on investment. that is our last slide. Mary put this slide in here, if not us, who? If not now, when? And I think that is a great question for all of us. We have not been included in meaningful use, but there is a lot of indirect that touches our ASCs, and it is very important as we go forward that we take the lessons learned and we provide better value for our patients in both making a safer and a more friendly and giving the patients that technology they need as they go forward to participate in their care.
Thank you very much, Mary and Cindy, for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A.
The first thing I want to say is we're getting some questions that are Cerner specific. And so if you have Cerner specific questions, rather than answering them on this webinar, I'd like for you to email them to me. So I saw on the list of participants that there were quite a few of our clients, which is a very good thing. So if you have Cerner specific questions that you might think that I could help you with, or I could send you to the right Cerner person, if you'll just email me at mary.whittington@cerner.com, I will be sure to get you to the right person and get your questions answered.
Excellent. So we do have a few questions here, and definitely feel free to continue typing in questions, attendees, if you're able to. But the first question I have is, this attendee says, my docs say they want to hold off on EMR until required. Can you talk a little bit about how to get the docs on board, or even just open to considering EMR? We are so antiquated, and I fear we've gotten the docs so comfortable with the manual process they have no idea of what it takes to maintain regulations and compliance, etc.
So this is Cindy. I'm happy to answer that question because that is something I ask myself every single day. Every time I walk into an ASC, how do you say the right things to the doctors? And that is really where my bear in the woods comes from, is that the doctors see your EHR as the bear in the woods. They've got to learn sometimes 4 and 5 different systems with the hospitals they go to. They've got systems in their office. A lot of them have been through 3 or 4 different EHRs. So they have some real horror stories to tell. And sometimes just starting that, opening that door with letting them talk about it is a great first step. But the next step really becomes education, and that does not happen overnight. It is baby steps. And a great way to do that is to start with a little bit of information and make sure it's positive information. At each MEC, have a bulletin board where you can add articles and information about EHRs and ASCs. There are a lot of really good books out there that you can read that will bring up some of the positive aspects, and begin looking for that value and that return on investment that you can start sharing with them. Because they have had bad experiences, it's going to take time to begin to overcome some of those fears, and the best way to do that is with information.
Absolutely perfect. The next question I have here is, do we know when ASCs will be held to meaningful use requirements?
Cindy, I'm going to let you talk about the work that you've been leading the charge with the ONC and the voluntary meaningful use criteria here, if you don't mind.
Okay, so happy to do that. The problem for us with ASCs is kind of that chicken and the egg. There is no meaningful use requirements for us, but our physicians have meaningful use requirements. Our hospitals have meaningful use requirements that are an indirect impact on us. So 50% of a physician's cases have to be done in a location with a certified EHR. If we don't have a certification, even if we have an EHR in our facility, we can't be a certified EHR because there is no certification process for us. And so we've been visiting with the ONC, which is the Office of the National Coordinator that oversees meaningful use, to ask for a voluntary certification. And what that has entailed is within Meaningful Use 3, the ONC added in the ability to carve out the difference between meaningfully using an EHR and the certification that vendors go through to have a certified product. And that would allow us to go to the certifying bodies who currently certified EHRs and create our own separate voluntary meaningful use certification program. The vendors who sell EHRs to ASCs would then go through that process to get their EHR certified, which would give us a certified EHR without having to jump through the meaningful use hoops and attest and report what the hospitals and physicians are currently doing. There is right now no timeline on that. It is something that we continually work on and meet with the ONC and CMS about on a regular basis. There was a bill that went through recently to exempt physicians for that 50% and to give ASCs a time to get that voluntary certification in place so that once we do have EHRs in our ASCs, they can be certified.
Excellent. Thank you so much for that response, and I have a few more questions lined up here as well. The next question I have is, are hospitals and physician practices using patient portals for outcomes measures?
That's a pretty new process here at Cerner, as well as probably with any of the other vendors that may be using patient portals. So what we're seeing is with the new bundled payments, those are going to be the requirements. And so if your EHR is developing with long-term in mind, then they are setting up the ability for patient-entered outcomes to actually happen within the next 12 months or less. So the more and more we see it move towards bundled payments, which pushes their outcomes out 90 days, then the more and more you're going to see that the patient-entered outcomes become a part of what a portal is for the patient at that point. So pretty new, actually, technology today.
Absolutely, that makes sense. Perfect. The next question I have is, this attendee is wondering, how do you stimulate an institution mindset when only focused on meaningful use?
This is Cindy. I will take that, since I sat at a table recently full of hospital meaningful use people, and we were given a lunchtime objective of being able to discuss what value is provided by meaningful use. And there was not one person at that table who could take their meaningful use hat off and stop looking at all the obstructions of why meaningful use is terrible. How do you meet this particular measure? They couldn't get past all of the meaningful use requirements to even have the discussion about what's good in meaningful use. How do you find the patient safety? How do you find the quality? How do you find the business value in meaningful use? And so to get an institution to actually take that hat off and have those discussions can be really difficult, because they're in the trenches right now and they are trying so hard to meet those meaningful use measures, to not get penalties, and to not have problems within their meaningful use objectives. And so I think having some really good questions in your pocket when it comes to meaningful use, to be able to say, the smoking cessation measure, are you really seeing any difference? Are you impacting patient outcomes? And if you're not, are there ways to bring more education? Are there ways to trigger more discussion? Are there other things that we can do beyond meaningful use to make those measures more meaningful? I think some of the frustration also is that we're turning in a lot of data and we're not getting a lot of data back. And so as an institution, you have to look at your own data and see where you're making improvements. We just started a new feedback process where we're taking our meaningful use measures and reporting them back on a monthly basis to talk about where we're doing well and where we've made impacts, and taking those out to the physicians, because again, that data can be very helpful when you're trying to change those physician mindsets to say, yes, this is hard, but look what it's done for us.
Absolutely. And then continuing on the topic of meaningful use, this attendee was wondering about clarification. Doesn't 50% of the doctor encounters for meaningful use include the many encounters for the doctor, or many encounters the doctor has with the patient in their office with their certified EHR?
It does. Yeah, go ahead.
Okay, yes, it does. Those encounters do count towards that number. When you're an orthopedic surgeon, that doesn't matter so much because you're going to see most of your patients twice in your office. You're also going to take some cases to the hospitals, and so that 50% threshold you probably won't meet. If you're a pain doctor, a GI doctor, a cataract doctor, then that may hit your 50%, which is why ASCA took that bill to make sure that we could get those encounters exempted for our physicians.
Absolutely perfect. Okay. And then another question I have here is, if ASCs also have portals and PRO requirements, how many apps and portals will our patients have to tend to meet the needs of all the various providers?
That is a really excellent question, and I'm glad this attendee asked it. I had surgery on my foot beginning of the year, and I will tell you that in order to be able to have my surgery done, I was in 3 different portals. So yes, this is a huge issue that the industry is going to have to address. The good thing is that they're aware of it now, and so there'll be work done around that, because physicians obviously have portal numbers to meet. Check the box how many of your patients looked at the portal. I think it's down to requirement of 1 or something, or 10 now. But yes, I think that is something we are going to have to address, and how do you marry all that information that may be different or impacting the patient from different directions. So like I said, when I had surgery, I had 3 portals, so definitely a concern, and definitely something the industry is going to have to address moving forward.
Absolutely. Well, I want to thank again our presenters for their excellent presentation, and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.
Thank you all.
Thank you.